Have you ever thought about what happens when you donate blood? Well, on today's episode, we are going to talk to a blood specialist who's going to walk us through that process. Hi, welcome to Health Journeys, a podcast about real human experiences in health and medicine. I am your host and healthcare advocate, Maritza Hasty. Health Journeys is all about discussing the diagnosis and treatments of diseases and exploring personal stories in pursuit of overall health and well-being from different points of view. Support for this podcast comes from Hasty Storytelling. Hasty Storytelling is a creative agency that specializes in production, brand strategy, and live streaming solutions. For more information, visit us at hastystorytelling.com. Hi, everyone. Welcome to Health Journeys. Today we have a really interesting guest because we're going to talk about something that you don't hear about too often, blood typing and what it's like to work in a clinical laboratory. We have actually my brother, John Cartaya. He is a clinical laboratory scientist. Hi, John. How are you today?
Hello. I'm here
Welcome.
on my day off.
Well, welcome to the show. So, John, we don't really hear a lot about what a clinical laboratory scientist does. So, first of all, tell us a little bit about your history, your education, and how it was that you ended up in this field.
Well, most clinical laboratory scientists started out as pre-med. Very few of us went into the field thinking that we were going to be clinical laboratory scientists, which I had never heard of. Anyway, but I went in as a pre-med student, and then when I graduated with my bachelor's, there was an opportunity to do a one-year internship to attain California licensure as a clinical lab scientist. Back then, it was called a medical technologist. And now they changed the name. So I thought that this would be a good half step between being making some money and then going to medical school. But medical school never happened, and I've been a clinical scientist for, let's see, it's going to be pretty close to 50 years.
Wow, long time. So, I
Yeah.
know we've had a lot of discussions about some of the experiences. Can you take us back to your first experiences when you first were working? I think you were
Oh my
talking
God.
about the lab being next to the morgue, and tell us a little bit about that.
Well, I mean, my first job was on the night shift. My first job was a laboratory, and I had a very memorable first night because I was by myself in the lab. I was responsible for doing a multitude of things, including drawing blood gases and running them. But anyway, that's besides the point. That night, that very first night, I had a labor and delivery patient that went bad. And she was bleeding to death, and there was at that time doing a cross match was a very a very labor intensive thing, and I spent all night in the blood bank cross matching bloods for this woman who died. And I thought that night, I don't think this is what I want to do. I think, and ever since then, every time I get a labor and delivery specimen in the lab, I immediately think back of that moment. So it was that night, the baby died and the mother died. And I remember them rolling them into the lab, the baby on top of the mother. And it was a
God.
very
Oh,
traumatic experience as a first night on the job.
how on earth then did you regain your composure to be able to come back again and continue your
Well, I
work?
mean, I was on the night shift, and it was a fluke that happened that night. Normally, the night shift is normally, only traumas that come into the emergency room, and they might need a unit or two of blood, and they'll do a blood count and some chemistry, some things like that. But that night, it was just a fluke. and I survived it. And but it left a scar because every time I see a labor and delivery specimen come into the lab, I give that top priority because when a labor and delivery patient goes bad, they can bleed out pretty fast.
Wow, that's scary and that's very frightening. And again, it's the things that normally we really don't hear about, and that's certainly quite a story. And I remember when you told me that story, and I never forget it. I always think about it myself. So let's talk a little bit then about blood compatibility, and what is it what is it that you do specifically when a patient is in need of a transfusion? How do you figure out what blood type they are? We all know A positive, B positive, but there's a lot more to it. Can you tell us a little bit about
There is.
proteins and yeah, and things like that?
Well, I mean, the main job that we do in the blood bank, and of course, I've worked in all areas of the laboratory, but I think that for this interview, we're mainly concentrating on blood banking or transfusion service, the way I understand it. But what we mainly do is we get specimens from different kinds of patients. We get specimens for people that are going to surgery, and there's the possibility that they may need blood during surgery. We get specimens from women that come in to deliver babies because there's always, of course, the possibility that they might bleed during childbirth. We get specimens from the emergency room because they want to, if the hemoglobin is down, they may want to transfuse the patient. We get a lot of specimens from the cancer center, from infusion centers for patients that receive blood chronically. So we get that is the main source of our specimens. When we get a specimen for blood banking in the blood bank, the normal test that they order is a type and screen, which means that we type the patient like ABO and RH, and then we, in addition to that, we do an antibody screen. In other words, we run the patient's serum against the panel against 3 cells that are of known antigen specificity. If the antibody screen is negative, and then it's a no-brainer. We just find ABO compatible, ABO and RH compatible blood for the patient, and we cross-match it, and out the door it goes. The problem is when, and the biggest nightmare for us in the blood bank is when we get a patient that's bleeding acutely with an acute bleed. For example, somebody that comes into the emergency room bleeding from the gastrointestinal tract, or a car accident, or a woman in labor that went bad. And we run that antibody screen that 90% of the time it's negative, but in a small percentage of the time it turns out to be positive. That's when our real job begins, because now we have to figure out why the antibody screen is positive, and we cannot release blood to the patient until we have concluded our studies for the antibody screen and have found blood that is negative for the antigens, that the offending antigens that the patient has antibodies against. A lot of times the doctors, of course, become very impatient, and they want to know how long. And so, when we first see a positive antibody screen, the only thing we can say is it'll be anywhere between 1 hour and 10 hours. I cannot tell at this point. So now the doctor has to make a decision. If the patient doesn't get blood within the next 20 minutes, they're going to die. If we wait 10 hours, the patient's going to die. So they have to weigh those factors, and they may possibly have to give the patient uncross-matched blood at that time. But we continue, with the identification of the offending antibodies that the patient has. Does that cover your
Yeah, no.
question?
And
Or?
so if if the decision is made to give that patient that unmatched blood, what could be the potential consequences?
Well, I mean, if the blood that the patient receives has a antigen on the red cells for which they have an antibody, they could have a hemolytic reaction, and when you have an ABO incompatibility, or there are um, some antibodies that are very hemolytic, like for example the JKA, the KID A's, and the Duffy A's. Those antibodies are very hemolytic, and if you give that to a patient that has an active antibody against those, they could have a hemolytic reaction, and which would mean that they break down red cells inside, intravascularly, and could have kidney shutdown and die. Most of the time, when a patient is bleeding profusely and they make the decision to give uncross-matched blood that could be incompatible, maybe not, maybe yes. Most of the time, they're bleeding so fast that the body doesn't have time to make the antibody, or to break down the cells. So it depends on the severity of the case and how fast the doctor wants to infuse the blood.
Go ahead,
Under
John. Go
normal
ahead.
circumstances, they can wait, and most of the time they choose to wait. And 90% of the time, it's an easy antibody to identify because we'll run the patient's serum against a panel of known antigen-specific cells, and then by a process of ruling out, we can determine the protein that the patient has, that we need to look for the antigen negative donor for that particular protein. So, but on a small percentage of the time, they cannot wait for the blood for the antibody problems to be resolved.
So with that in mind, can you think of a situation where a patient, time is of the essence, you're trying to do all this cross matching, it's not possible within that time frame, so they give them the unmatched blood and that
Mhm.
patient ends up dying? Have you
It
had
happens.
that happen? It happened. And how about
It
for
has
you
happened.
personally, when you know that, or when you feel that, how do you feel personally that you wished you could have done more, or is something that you just have to kind of release, and it's now the doctor's responsibility, right? It's their
No, our
responsibility because
stress
they made that
level,
decision.
the doctor is responsible for making that decision, and I don't feel responsible at all. I continue my work, and I continue my antibody identification as fast as I can, and but no, there's no guilt feelings involved in that kind of decision at all, because if it's kind of a catch-22 situation. They either don't get it and die, or they get it and may or may not die. So you have a better chance by giving them uncross-matched blood that could be incompatible. Most of the time, it is not. Most of the time, um, there's no reaction. Occasionally, there is. Most of the deaths that have occurred in the blood bank are due to ABO incompatibility, and they are because of patient identification errors, which is, by the way, it has been the biggest reason for death in the field. Um, Laboratory error, or errors in labeling the specimen, and then the patient ends up getting the wrong ABO group type, and that is very hemolytic, and they can die instantly.
Yeah, that's
So
that's
we take a
definitely
lot we
scary.
take a lot of we take a lot of precautions to make sure that that doesn't happen. In other words, when I get a blood sample in the blood bank, and I do a group and type and say the patient is A positive, and I look in the computer, and if the patient has had a previous history and it shows that the patient is in fact A positive, I proceed. If I see no history in the computer, we require a second tube to be drawn by a different person at a different time and sent to the blood bank for a repeat ABO and RH, so to confirm that that is in fact the correct patient type. So if we don't have a history, we recheck it by a different um, person that drew the blood and at a different time and has conducted the patient identification 2 times independently. So
Well,
that's
that's
one of the
good because we have,
safeguards that,
yes,
that we have.
safeguards. Yes. John, in our conversations, you had mentioned that we're talking about proteins and antibodies, and I know for the average listener, they're kind of trying to process it all. It's a lot of information. But you also talked about some distinctions between certain races and ethnicities when it comes to cross matching. Can you tell us a little bit about that? You had mentioned that sometimes blood has to come from Honolulu for a lot of the Asian population.
For
Can
some,
you maybe
yes,
tell us a little about that?
for some very rare um, antibodies, and usually I can think of one recent, and I don't remember what the antibody was. I think it was a combination of kit A and kit B. And most of the people that are negative for those 2 antigens are of Asian origin. And the blood banks here in California did not have any blood that matched those specific antigen types. So we finally had to, it finally came from Honolulu, from the blood bank in Honolulu. And yes, I mean, blood types, ABO, for example, 44% of Caucasians are O. 49% of African Americans are O. Most people are O. But we're talking about the other antibodies that you, or the other antigens that are on the red cell that nobody really mentions, and most people that don't work in a blood bank or in that kind of setting, you never hear of them. Um, so including the RH and several others. But
Okay.
yeah, sometimes because of race, we have to resort to regional type of blood banks to be to in looking for compatible blood for those patients.
Again, interesting because if there was an emergency situation or we have to go to the hospital or surgery, we kind of automatically think that everything is there and ready to take care of us if something happens. So interesting to find out what you go through in certain situations. I know that you've mentioned that you could be at work and things could be really quiet, and then all of a sudden things can go into a panic. Can you tell us
Mhm.
about an instance where you had an emergency and you were just kind of like, I don't know if I can take this. Can you kind of take us through that?
Yeah, often what we have is I'll get a call in the blood bank and they tell me that we have a massive transfusion request. We need massive transfusions for a particular patient. I don't necessarily know what's wrong with the patient, and I don't see the patient. All I see is the blood sample and the panic words on the phone that are requesting a massive transfusion. When that happens, if the first thing I do is I look in the computer and I look to see if I have a specimen on that particular patient. If I don't, then I begin to panic and I tell them you need to draw me a sample, and we never refuse blood, so we take 5 units of O negative blood from the refrigerator. We take 2A platelets from the platelet rotator, and we give them 2 units of fresh frozen plasma, all without any paperwork or anything to go out, because we know that when they order a massive transfusion, it is very stressful. And that's one of the most stressful times that we have in the blood bank, because then after we do all of that, then we have to recover from it and hope that everything when we test it is negative. If it's positive, then obviously there's a problem there. But yeah, it can be very stressful. When I get a call for a massive transfusion, I panic, and so does everybody else.
I know we've had these conversations before where you'll tell me, you're like, oh my gosh, today, that's it. I thought it was going to be my last day. So I wanted people to kind of get a feel for what you feel and what's going on and how stressful your job can
It
actually
is.
be.
It can be very stressful. Yes. Fortunately, if you work in a trauma center, obviously that is an everyday occurrence. I work in a relatively quiet hospital where most of the requirements for transfusion are patients in surgery. Occasionally, there's a patient that starts bleeding in surgery, and they'll call and they say, well, we have a massive transfusion that we need. But in those cases, usually I have a specimen, and then it becomes relatively easy. I just ship out 5 units at a time, and they infuse them to the patient, and they come back for five more, and it's relatively simple. It's when we don't have a specimen and we don't know the patient's type, and of course, since we don't know the patient's type, we're giving them O negative, which is the universal donor, and it's compatible with everybody. So
So when you were managing the lab,
yeah.
I know that you were in an area that had a lot of high profile
Oh, okay.
celebrities. And so what was it like when they were coming to the lab, and how did you manage that? Because I'm sure everybody was going crazy. And what did you have to do to have business as usual and continue with your usual day?
Well, usually high-profile people don't come to the lab. They're wealthy enough to where they call and somebody goes to if they live locally, like in the case of some of the celebrities that I can think of over the last 30 years that I've worked, we've gone to their house to draw their blood. There's one instance that I can think of where a celebrity came into the lab with their baby. They had just had a baby, and they brought him in for a bilirubin test, which is a common test that they do on babies. And all of a sudden, all the nurses had a reason to come to the lab and walk through and look at this person. And of course, the laboratory people were also looking. You can't help that. And they're
Right.
there, and they know they're a celebrity, and what can you do?
Yep.
We've had other
And
celebrities that were admitted to the hospital, and they come in under an alias. Usually, they don't come in under their names. And
oh
the
yeah,
people that
yeah.
draw them are sworn to privacy. And we had one celebrity that I can think of not too long ago that management or hospital administration was constantly checking the computer to make sure that people weren't snooping into that person's
Oh,
files.
interesting.
Yeah, that
Interesting.
was a young rocker that came in, and
Wow.
yeah, we've had several of those, but you deal with it, and there's HIPAA requirements where
Yeah,
of
of course.
confidentiality. So I
Right,
can't
right,
tell you
right.
who they are, but I can tell you that I've seen them.
So what's it like to go to a celebrity's home and actually draw blood? Did you draw the blood, or what was that like?
Uh, Actually, I had to draw a celebrity's blood once, and I missed because I was so nervous.
Oh gosh.
And luckily, my fellow worker, who was also my boss, she tried, and she also missed.
Oh gosh.
so, so yeah, yeah, that was a celebrity that lived nearby the hospital, and of course, all celebrities live near Hoag Hospital in Newport Beach. But yeah, I
That's
mean,
funny.
it's not. I don't enjoy doing stuff like that. I'm basically an introvert, and I don't like. Never liked drawing blood, and but occasionally I had to do it.
But I do remember back in the day when you first started and you used to draw mom's blood and you've drawn
Yeah,
mine. And I remember that in our kitchen table.
yeah. I
Remember
mean,
that?
of course. I mean, back in the days, but now we have phlebotomists that do all the blood
Yeah.
drawing, and we have
Right.
certified phlebotomists that go around drawing blood, so the clinical lab scientists don't have to go out and draw blood anymore.
Yeah.
Occasionally,
Yeah.
in some hospitals, we have to go out and draw arterial blood for for blood gases, but I haven't had to do that in many years, and I hope I never have to do it again. I'm on my last
That's
leg, and I'm
painful.
retired.
I
And
can speak by experience. Getting a blood gas hurts. That's very
yeah,
painful.
it
Um,
can be very painful.
yeah. Oh, yes. So, okay, so we're going to kind of maybe get a little serious with it. So, with the pandemic, with COVID-19, since that's the big thing right now, how has that affected the blood supply, and how has that affected your job in particular?
Well, oddly enough, I hear in the news that a lot of areas in the U.S. Are people aren't donating because they're afraid of the COVID-19. Oddly enough, we get our blood supply from the San Diego Blood Bank, and people have been pouring in, donating blood left and right down there. So we have not, locally here, we have not had a blood shortage. Although it's always good to remind people that they need to donate because there's always a need. And usually our blood shortages come during holidays, Christmas holidays and Thanksgiving and things like that. But we haven't experienced in Orange County a significant shortage of red cells as they have in other parts of the country. I'm sure New York has experienced a big shortage of blood, and I don't know if San Diego has been shipping blood out to other states or something like that. We used to get blood from the American Red Cross. Now we're getting it from San Diego, and it's all about contracts and things like that.
But if the listeners that are listening today, if they want to help and they want to donate blood, they can feel that it's a safe process with the pandemic, and they should feel
Oh,
comfortable being able to do so.
absolutely, yeah. Yeah.
That's good to know.
There's no reason to be concerned about about getting the COVID-19 virus from blood donation. It has nothing to do with blood. It's transmitted uh, uh, by oral or exposure to other people, close contact with other people, but not by the blood,
Very good. John,
like
based on
HIV was
all,
back in the day.
yeah, yeah. So based on everything that we talked about and all these different things and proteins and antigens and everything that you talked about, cross-matching blood, when a family member has either whether it's a very serious illness or something that they're
Hmm.
facing, a very serious operation, can the family donate blood when we find that they're compatible prior to scheduling this surgery or prior to scheduling this procedure? Can we as a family donate so that that blood is already banked and prepared should something serious happen?
There are two programs. There's the autologous donor program, in which, if you know you're going to have surgery, like say open heart surgery or something like that, you can go into the blood bank and donate blood to yourself. So you might want to start, like, a couple of months if there's time before your surgery, to donate blood to yourself until you have reached, like, however many units the doctor thinks that they might need during surgery. That's the autologous program. Then, when the blood is drawn, we bring it in, and when the patient comes in for surgery, obviously it doesn't need to be cross matched or anything because it's your own blood. So that's one program. The other program that we have is the directed donor program. So, say that a family member is going in for surgery and they're too weak to donate their own blood, or they don't want to donate their own blood because they're having surgery and they're afraid they're going to be anemic or whatever. You can go in and donate under their name and say, this, I'm donating this for patient John Smith, and that blood is, obviously that's not the patient's blood, so when it comes in we do have to cross match it like a regular unit. The problem that we've seen with that and I'm going back to the HIV epidemic, not so much presently, is that people would be put under pressure to donate blood for a relative or a friend or something like that, which we felt would put the patient more at risk, because if these people had been exposed to HIV for some reason, they wouldn't disclose it. And
Oh,
even though they did the testing for HIV and all of that, but it's still, you put pressure on people to donate blood, who otherwise may not go donate blood because of a specific reason. And
okay,
during the
okay.
HIV epidemic, it was HIV. So,
Yeah, yeah, yeah.
so
Okay,
and that,
interesting.
and one unit
Go
could
ahead.
taint
Abs-
the blood bank system. So, um, I heard of a lot of cases like that where, for example, they ban homosexuals from donating blood. But if there was a family member and it was a closeted homosexual, they'd feel the pressure and they'd go and donate blood anyway. So that was a problem with that, with the directed donor program. I don't see too many directed donors anymore, and I don't see too many autologous. The programs are still active, and we still
mhm.
accept them every once in a while. But most people feel pretty comfortable with the testing that we do in the donor centers. That we screen the blood real well, and there's of course an interview before you can donate blood. And if you fall in any group, like you traveled in a certain endemic area or something like that, they won't take you. Or if your hemoglobin is lower than a certain amount, they won't take you. I think they're making some exceptions right now because of the COVID-19 epidemic. They're
Mhm.
releasing some of the restrictions that they had before, and I don't know if that's going to be temporary or long term.
Does that worry you
What
that
the
the restrictions are a little bit more relaxed? Does that worry you at all with respect
No,
to the
no, not
quality
at
or to
all,
the,
not
no?
at all.
So you
The
still
blood
feel the quality?
supply is very safe. The blood supply is very safe, and
Good.
if
Okay.
they so most of the restrictions that they're lifting are drug related. If you're on a specific drug, you can't donate for some reason, and but I don't know the specifics. So I just know that they've because I don't work in a donor center, but I know that they lifted some of the restrictions to get more people to donate during the pandemic.
And we know that there's certain disease states or there's certain conditions that preclude you from being a candidate to donate.
Of course, yeah,
Yeah. Yeah. So
a
they'll screen
million,
them for that.
yeah.
Yeah. Can you maybe name a couple that, that
Well, I
are
mean, if you have cancer, obviously you can't donate.
okay.
If you have any of the blood dyscrasias like thalassemia or uh, malaria, or there's a lot of, if you've been in a malaria um, country where malaria is an epidemic, then obviously you can't donate. Um,
Right. Right. Okay. Well, the bottom line is that you feel really comfortable with the screening process and you feel
oh
that
yeah,
even though we're going
the
through this pandemic, that the measures that are in place are still safe measures is bottom
the
line.
blood
Yeah.
supply is safe. I've never seen anybody uh, get sick from the blood supply. They test all the blood for hepatitis and HIV and all the other new, mad cow disease and all the stuff that
Good
has
to
come
know.
up recently since I worked in a donor center. It's been years since I drew donors.
So, John, finally, if our listening audience wants to get more information on where to donate blood or where they should go, I know you mentioned the American Red Cross, uh, the San Diego, is it the San Diego Blood Bank? Is that what it's
Blood bank.
called?
Yes. San Diego
San
Blood
Diego?
Bank. They have
Okay.
draw centers up here in Orange County. In fact, there's a draw center in at Hoag Hospital where San Diego Blood Bank has a donor recruiting
Okay.
station. And of course, they can donate in most of the major hospitals have donor centers like Memorial Care. We have a donor center at Long Beach, and we have another donor center at Saddleback Memorial in Laguna Niguel or Laguna Hills area. We
Good to
do
know.
not have a donor center where I work in Orange Coast because that's a smaller hospital, and if we need if we need blood, we get it from San Diego, or sometimes we get blood from the sisters hospital. So, yeah.
Great. Well, thank you. Thank you so much. We learned a lot today. We learned all kinds of things about blood matching and cross matching, and we learned about maybe thinking a little bit about ourselves if family members or we're going to be undergoing some procedures and hospitals to kind of know a little bit more about what happens. And finally,
Mhm.
hopefully nobody has to go through a traumatic event or some type of an event where they need a fast transfusion, because we want you to be able to take your time and make the right match, right?
Yeah, and we do. We
So,
take our time. It's
yes,
just that sometimes they can't wait, so they have to give
right,
uncross-matched and unprocessed blood, and you know, it's something that the options that the doctors have to weigh in the emergency room or wherever the case may be. Um,
right.
they have to make a decision, you know,
Yeah.
what's best for the
Yep.
patient under the circumstances.
Well, thank you so much for letting us into your life and to letting us into knowing what it's like a day in the lab. And we appreciate it, appreciate the time. And with that, I'll probably see you this weekend.
Okay.
Support for this podcast comes from Hasty Storytelling. Hasty Storytelling is a creative agency that specializes in production, brand strategy, and live streaming solutions. For more information, visit us at hastystorytelling.com. Health Journeys is produced by Victoria Bilionis and executive producers Dennis Lovelace and Greg Hasty. Finally, if you're enjoying the show, please subscribe, tell a friend, and visit us at hastystorytelling.com.